Okay. Dear colleagues, dear students, dear guests, dear all, today we have a very interesting webinar and a very good friend of us, Professor Lukman THALIB, as our speaker in this webinar. He's a distinct academic with a very high profile, and it's our honor to be colleagues with him in this campus, in our university, in our medical faculty. Professor Lukman THALIB had his bachelor degree in biometry in 1985 in Sri Lanka, and actually he was born in Sri Lanka. I don't know when, but then he went into applied statistics in University of Reading in UK and had his master's degree also in the same university in 1989. Then for his PhD, he went to University of Birmingham, again in UK, and had his PhD degree in biostatistics in 1993, and made his postdoc in Australia first for the program graduate certificate in higher education. So he's a higher education educator also, and another postdoc process in 2007 in Dundee University in UK. He had a postgraduate certificate again in Australia. In his academic career, he worked as lecturer in Australia, Griffith University, in Faculty of Medicine in Kuwait for 15 years, as a professor of biostatistics for 5 years in Qatar. And then after Qatar, he came to Istanbul, and also he kept his post. I mean, it was continued. He kept his post in Griffith University, Australia also. Professor Lukman THALIB is an Australian citizen, in short, and had his academic degrees and advancements, let's say, in different countries, and so he's an international personality in reality. His research expertise as a medical statistician is focused mainly on medical data analysis, systematic reviews and meta-analysis, and evidence-based medicine, due to his certificates in his postdoc period for lecturing and for teaching in higher education and in medicine also. I said he has a high profile. He has an H index of 54. Oh my. And over 700 citations international. And he produces, he's very productive actually, he produces up to 20 papers lately per year. And all of these papers are, I can say, or at least 99% are Q1 papers. So we're very happy to have him, not only that he's a high profile academic, but also that he's a very good friend of us. He's very friendly, a very good sharing person. He's very, modest and humble, and he's always, he radiates positive energy, and he's a very hardworking person as a whole. So now he will talk about meta-analysis, and during during his last 10 years, maybe he can say it better, he was focused mainly on making meta-analysis and writing papers about these meta-analysis. So today we will see how these meta-analyses are done and what the differences are in making the meta-analysis, the differences between other reviews and meta-analysis, and what the benefits are, or if there are any risks, what they are, and so on. Meta-analysis is is having a whole thing, a whole view. So this is what we need actually in medical diagnosing and medical therapies in every step, because it gives a precise outcome of what has been done up to that date. So Professor Lukman, you can take the stage.
Thank you very much. Thank you very much for such a generous introduction, Professor Hojam. Everybody call her Çiğdem. I'm calling her Zainab because I have a daughter also named same as yeah. Thank you very much. It was very generous. Ladies and gentlemen, welcome to the seminar, and hoş geldiniz. That's Bukada, that's all my Turkish. Inshallah, I learned a little bit more.
Yeah, he's learning Turkish quite rapidly.
Not too much. I hope everybody can see the screen and hear me well. And if there's any issue, Artha will alert me. Okay. So, as usual, I like to kind of start with stories. I believe I don't know why I just got this bad or good practice of starting all my lectures, presentation with stories. This is actually not a story. It's a really true event that happened to me. It was 1990. I was studying, doing my PhD in Birmingham University, and my wife had a child, our first child, was born in Birmingham Queen Elizabeth Hospital. According to the National Health Service, I don't know if they still have that good practice, but what they used to do when the babies are born and within 1 or 2 days normal birth, they discharge the woman and the child, and then 10 days a midwife will visit the family to my wife and help her with feeding and cleaning and how to put the baby to the bed and make him sleep and all kind of things. Really good. I don't know whether you have similar program in Turkey. I was very, very impressed with the program. So it was very helpful because me and my wife only, so they would come 10 days every single day, sit with them, nutrition and good health and so on. So one of the things that my wife was advised is to put the baby on the stomach when they sleep. So it's cold there, and they wrap the child up and put the baby upside down, like in the second picture, not the first picture. And I wasn't comfortable at that time, but I wasn't sure why and what kind of evidence they had, but I was too busy with my PhD to look at any evidence. And there was no internet or Google at that time for us to look at. So the advice that was given by National Health Service or NHS in England was to put the baby on the stomach when they want to sleep in the cot. And also this is the same advice that has been given across English-speaking world in Australia, New Zealand, in Europe, large part of Europe and US. Now, I hope this graph tells you some story. Now, what has been happening is until this was 1990 when my first child was born. So they were still giving us advice to put the baby on the stomach, not the way the picture is. And then what they found out, now we know, not at that time, when this advice has been going up from 1970s to put the babies on the stomach to sleep, there is something else was going up too. That was the cot death. I don't know what's in Turkish term. It's a SIDS, sudden infant death syndrome. The child just suddenly die in the cot. Cot death, they call it in a simple English. And so as you can see the graph, until 1990s, the cot death has been going up. And then after 1990s, I wasn't part of that. I was advised to put the baby on the stomach. 95 around, I'll show you when it happened. The advice changed and said, no, don't put the baby on your stomach, put the baby on your back. And then you can see what the cot death keep coming down, and it's pretty low right now because now the standard advice is to put the baby on the back. Now, why is it important? Why am I telling you this story? You will know in a few minutes. So if you look at this, this is where the issues are. You see, those days, I don't know, I'm pretty old, to be honest. I don't know whether people who are audience are young, they probably don't know that they were born in a Google world. So we didn't have Google. When my child was born in 1990, we didn't have a Google access, no World Wide Web. And then we always have books. I remember I had this book, Benjamin Spock and Mariam Stoppard. I had this book. When a child is born, they used to give these kind of books. And we bring up our children using book. When do they have the first teeth? When do they start walking? When do you give the solid? We read these books. You know, they are interesting. They're given as a gift. I don't know the Turkish tradition. That was the case in England at that time. So Dr. Spock wrote this book in 1956, where the picture is the baby is sleeping on the stomach. And inside the book, this is millions of copies are sold in English-speaking world and translated into many languages. This, he advises that the baby should be put on the stomach, then they'll sleep well and it's good for them. So it started in 46 and 50s, and the book edition 56 is still showing the babies put in the stomach. 60s. Now, cotlet started to come up, and in mid-60s, there's already studies are showing that putting the baby on the stomach may be one of the causes for airway blocking and dying in the cot. And there were other studies in 70s, and there are a number of studies here and there from different parts of the world. And then 3 further studies in the mid-80s. Still, the numbers are going up. Cot death has not come down. And mid-90s is the UK did the study. And only after mid-95, US started to make a campaign that sleeping on the back is better. And the first systematic review was published in mid-2000. So although we had evidence in 70s, mid-60s and 80s, until 2000, middle 2000, 2005, to be honest, is first systematic review got published. And then the guidelines got changed and the book also changed. As you can see, the newer book, the baby is sleeping on the back nicely. And so we had all this time, we had evidence, but we have not systematically collected the evidence and compiled them. As a result, how many million babies were killed due to cot death, you can imagine. Actually, this was calculated. So this is in 2005. Ruth Gilbert is a friend of mine. I was sabbaticaling with her a number of times, and I was teaching evidence-based medicine to doctors in England. She works in Institute of Child Health, University College London. One of the great lady. I mean, she pioneered evidence-based medicine in England. Pediatrician by training, but then she got into evidence-based medicine. Now she's a very solid epidemiologist. And she wrote International Journal of Epidemiology. She did the first systematic review. That was published in 2005. So infant sleeping position and the sudden infant death syndrome, which is cot death, systematic review, observational studies, and historical review from 1940 to 2002. There was so much data there, but it wasn't published or known until 2005. In 2005, I remember she was all over BBC, ABC, everywhere. I remember when I was visiting, she was so busy with the media, telling the world, let's change it, let's stop kids being killed in the cot. So Ruth Gilbert wrote in the International Journal of Epidemiology, the topmost journal in epidemiology, advised to put infants to sleep on the front for nearly half a century, 50 years, was contrary to the evidence available from 70. The problem is we did have evidence from 70s. If you only care to put them together, look at it. It's not that we didn't have, we had it, but we did not look at it, we did not accumulate it, we did not act on it. So until 2005, Ruth published this systematic review, it wasn't clear to the world. And of course, once you publish a systematic review, how long it goes in time, how long it takes before it goes into guidelines, and then from guidelines, how long it takes into practice is another story, another seminar, an area that I'm always interested in, the guidelines. I don't know about the guideline stories in Turkey. I had to learn one day. But the issue is evidence was available, but we didn't. So she further said, systematic review of preventable risk factors for SIDS. It's really preventable. Put the baby on, not on the back, on the back, not on the stomach. From 1970 would have prevented over 10,000 infant deaths in the UK alone, and at least 50,000 infant deaths in Europe, USA, and Australasia. So we're talking about 60,000 infants being killed because we did not look at the evidence. We did not do our job correctly. So I don't know, any of you know Ian Chalmers, one of the wonderful scientists from Oxford. I really like him, and we got a lot of things in common. He's a very much health equality guy. He fights for the health for all, and you know, he would go to Gaza in the whole middle of everything and do evidence-based medicine in there. That kind of courageous man. But, you know, work on various health of people who are affected in different parts of the world. He calls it scandal. It's a scandal for scientists to not to accumulate the evidence, not to put them together, not to look at what's available and then put it into practice to save life. I mean, I agree with him, Ian Chalmers. I hope we can bring Ian one day here, and it's just so inspirational a person, very NTO as well. So that's where I come with him. Okay, so what's my plan? Having said the story, I hope people got the idea that if you don't accumulate the evidence appropriately and we are not in a good shape, I mean, we are doing harm. And when there is already evidence, there's already publications, and we should actually accumulate them, look at what does the total evidence shows in a particular question, so we can improve our healthcare and health delivery and practice. So the plan for today very quickly is, what is systematic review? I'm going to not assume much because there are students here. So sorry for people who already are very familiar with. I know some of you are already doing systematic review, but I'm going to take it from a very slow, yawash, inshallah. And then I'm going to talk about narrative versus systematic review. What are the difference? What are the development? Then I'll move on to most of my seminar is going to be on meta-analysis. What is it? Why? And how do we do it? When do we do it? And I'm going to show you real life example. There's no point of showing you all the formulas and mathematics behind it. I'm going to focus on showing you some real life examples, and hopefully you could get some ideas about it. And then if I could inspire you to do some meta-analysis, that would be the success of this webinar in my point of view. So what is a systematic review then? Okay, so what is it? I mean, the standard definition would say, identify all the evidence related to a particular question that you have. You have a clinical question related to diagnosis or related to treatment or prognosis or risk, like Chidam said. And then you have this clinical question, okay, COVID, should we give steroid or not to give steroid? Should we give antibiotic or not to give antibiotic? Does it reduce the mortality for ICU patients, and so on and so forth? And we consolidate all the published evidence available to answer a specific question. That's all, that's simple as that. As you can see, where you put all those studies into a process and you get the kind of final answer, which we believe is much more stronger and much more evidence-based. Now, just to get you some background about systematic review, why is it called systematic review? What was before? Actually, before 1990s, there were no systematic review per se, there were more narrative review. So we would ask some expert in the field, they were always experts, can you just write an article on, I don't know, diagnosis of toxoplasmosis, you know, how do you do that? Or the treatment of particular infection, how do you do that? And then he would sort of look at whatever he wanted to look at, and all his bias and whatever he done, he'll just say, this is the conclusion. So single-handed expert coming out and writing a review, that's called a narrative review. There's no process of systematic collection or methodology. So the problem with such narrative reviews before 1990, still there are a few hanging around, one or two, but most of it is gone, and most of the reviews now, thankfully, are systematic review. You can't publish them if it's narrative. Still, there is some room for narrative review for areas that are totally new. So the problem with the narrative review is subjectivity. If I am more biased towards antibiotic prescription, my subjectivity will be there. There's no transparency. How did you do that? I mean, it's an expert, whatever the way he chooses to do it. and concluded. He did that. Whatever the study he wanted to include, he include. Whatever the study he doesn't like, it exclude. And there is no systematic inclusion exclusion criteria that is very clear and defined before he doing it. Doesn't exist. And what's more interesting is there are so many narrative review published on the same clinical question, but they come up with a different, diametrically opposite conclusion, because obviously this person is pro-antibiotic, this is anti-antibiotic, and obviously they're going to say yes or no, and there's always conflicting answers because there's no systematic process involved. And the synthesizing data, is there, do they synthesize them in a systematic way? Like meta-analysis is not part of the narrative review. Meta-analysis came much later during the process. Okay. So very briefly, this picture, I'm not going to spend too much time on it. So if you look at it, narrative review on the first row, and ignore the other kind of review. Systematic review on the bottom. Of course, narrative review is very fast because you just depend on research area. You're an expert, you're going to talk about it. And the systematic review is slow because it takes time, sometimes 1 year, 2 years, because sometimes if there are no publications, you might have to contact people who are currently doing, because we like to include all the papers that are even currently be done, if possible. It's not a month. And methodologically, there's no method. You know, narrative review, you choose the method, but now systematic review has a very clear methodology. The researchers, scientists, evidence-based community has agreed upon following these kind of steps that are very, very important in systematic review in terms of inclusion, exclusion, collecting the data, and how do you look at it, and assessing the bias. This is one of the areas is risk of bias. There's a lot of very high risk of bias. There's no assessment of risk of bias. In the systematic reviews, there is a proper assessment of risk of bias of each of the papers and much less risk of bias. I mean, you know, biased finding. Comprehensiveness, of course, depend on the author. Author decided to only include some of the papers, not all of them. So it's not comprehensive. Systematic review cannot be systematic unless it's very comprehensive. You included all of them, whether you like it or not. All the papers related to the topic that you are included, that you're interested, you're studying, had to be included. So the systematic reviews are comprehensive, less bias, more methodologically much more rigorous. It is slow as a result, it takes time. Whereas narrative reviews, there's no systematic method, solely depend on the expert or the author who writes it, and it is very much, it can be fastly done because there's no systematic way of going through. So what is meta-analysis then? Okay, so meta-analysis simply is a statistical method combining quantitative results. This is the most important thing. Systematic review could be qualitative or anything. It doesn't require any mathematical methods. It is a more, so when you're using the quantitative, mathematical or statistical method, taking the numbers from each of those studies that you're systematically reviewing and pooling them together to give an overall summary, we call this overall summary measure. Like, for example, if you're taking a relative risk from 10 studies and you're pooling all those relative risk in a systematic way using meta-analysis, the overall relative risk is the estimate that we think is more precise, more powerful, is better evidence that could be gotten into the guidelines, and you can use that for your clinical practice. I'm going to show you a real example, so don't worry if you didn't follow it through. Now, this is a sort of simple figure which shows study 1, 2, 3, 4. Suppose you included 4 studies in a meta-analysis. You take the numbers from these studies and combine them and systematically, and then you analyze them using meta-analysis and so on. So you're going to see it. I'm going to show you a real example. I think I took a simple example that everybody can understand. Let's see. Before I go into an example, I'll try to go slowly on the example. As you can see, this is only up to 2011. I need to update this graph. Number of systematic reviews published, as you can see, is going up exponentially. Number of meta-analysis per year from 93 onward is going up steadily, 10,000. Now it's going even further. Every day systematic reviews are published. If you go to PubMed, now there is a filter. If you click systematic review or meta-analysis, you can see all the new meta-analysis published. The reason why meta-analysis and systematic reviews are published more is because, as you know, the guidelines developed for the hospital guideline. For those who are working in the hospital, the students probably will soon, first year, second years, you will know that when they go hospital, they talk about grade 1 evidence. or I don't know how they call it in Turkey, class A evidence, class 1A. They come from meta-analysis or systematic review. That is the highest level. Then the randomized control studies, then the cohort, and so on. So the highest level of evidence for a particular clinical question in terms of treatment or a diagnosis usually come from a well-done meta-analysis. So there is, this is what, as you can see in this graph here, this is the level of evidence going up, and the animal laboratory studies are low level of evidence, the basic evidence, then you go the case control studies are low, cohort are little better, randomized control study for treatment are much better, of course stronger. Then the meta-analysis of and systematic reviews of the randomized control trials are very strong. And you can also have a meta-analysis of cohort studies that's not as strong as meta-analysis of randomized control trial. Then of course, clinical practice guidelines, CPG, are finally using the best available evidence and is keep updated every few months, hopefully. Not sure about the process in Turkey. I wanted to study, but I've been busy with so many other things. You know, the international guidelines like NICE guidelines, Scott guidelines, so clinical association like American Cardiology Association, American Pediatric Association, and so on. They keep updating the evidence mostly based on meta-analysis. So meta-analysis is very critical for clinicians today because they are based on that. Of course, the pharmaceuticals wanted to sell their medication. They fund the meta-analysis. You have to be a bit careful with that. Pharmaceutical funded meta-analysis, they'll bring your meta-analysis paper with their briefcase and a tie and a coat. Doctor, we got the new meta-analysis. This is the new medicine. It works perfectly. And you're going to see it. I don't know the process in Turkey, but I saw it in Middle East always. When I walk around the hospital, I see this well dressed up, handsome guys coming around from pharmaceutical, trying to sell their medicine with the meta-analysis, one hand in their briefcase, the medicine on the other. And there you go, makes much million. I'm not against pharmaceutical millions, but some of them are really not always justified. So as a clinician, you need to be able to assess them. Is this meta-analysis right? Is it really a good one, or is it biased? Did they throw out some of the papers? And so that's another discussion. I'm not going to go into that. Let's look at an example of meta-analysis. Before that, these are the very simple steps. You define your questions for a PICO. You have a population, intervention, control, and outcome. What outcome in the patient that you're trying to control? Say, for example, you're interested in death, mortality among COVID patients admitted to ICU, and should I give a steroid or not to give a steroid is your question, and the population is the COVID patients admitted to ICU. Now here question is, you're trying to see what are the best available evidence. So you collect all the studies related to steroid, and they measure the mortality in the COVID patient. Only the COVID, of course, that's the population. And then you extract data from these studies, each papers, you don't need, this is the great thing. A lot of my master's students loved it because they don't need to go and beg around for data from different places. The data are all published literature. So you take the papers, you extract data from them, and then you analyze them using meta-analysis, and then you can publish it, and you also get a better idea about what happened. Okay, so Artha, is it clear? The voice, everything clear before I go into explaining?
Yes, everything is clear, Professor.
All right, thank you very much. I usually like face-to-face, but that's fine. This is the world. So this is an example, a real example. So I'm only going to show you some real example. This is interesting. This was published in JAMA Internal Medicine, one of the very high impact journal, and this was a very evidence-based journal. McMaster people who are driving it now. McMaster is driving the BMJ, British Medical Journal. I think JAMA and McMaster had some issues right now. So there were two papers published, one on Lancet, the parallelly, and then internal medicine. Exactly the same kind of thing. They independently did it, but they didn't know that each one is doing. You know, one didn't know the other one was doing. So two groups were publishing at the same time. I took the JAMA one, is much easier, but the Lancet paper also published on the same thing. And how easy they could go into very high impact journal. These are very high impact journals. So what they were looking at is CABG, which is, as you know, bypass grafting. Students should know. You just they call it open heart. They don't open the heart, but they open the chest, and then you graft the blocked arteries, you cut it and you stitch it. And then versus the stenting, which is the PCA, you could just send through your hand or from whatever, send your stenting. I'm sure the students are aware of the stent and the grafting. And which one is good for a long-term mortality? Okay, so this particular systematic review is trying to answer the question, CABG is good or PCA is good for the long-term mortality. It's funny that I had to face this question, and then Çiğdem Hoca, I had myocardial infarction, and then Çiğdem Hoja sent me to Istanbul University for the top team. They would obviously follow these guidelines and give me an answer, which I knew that is the right answer, but then I went for that. I'm going to talk about that later. For the moment, let's try to understand this. I think Çiğdem Hoja is laughing. She knows what I'm talking about. Others will understand later. I'll come back to this story if we have time.
Okay, I thought it's all over here.
Yes, it is. Yeah, is it? Okay, so to determine the idea is CABG, which is the bypass. Do they call it bypass? I'm sure students know bypass versus the stenting PCI, which is good for long-term mortality. Because we know about the short-term mortality, we know about a lot of the other things, about quality of life and so on. But this is very important. Which one? So if your grandfather, hopefully not, or if your friend or somebody, hopefully I don't wish for it, had a multi-vessel disease or block on the heart, what would you use? What would you recommend? Or if you're a cardiologist, actually, I used to teach cardiologists evidence-based medicine. When this paper came up, I did for them and I asked them before I show them the answer, what do you think is the answer? A lot of them put their hands up, including the director as a PCI. So we're going to see the answer, which one is good for long-term mortality. I hope the question is clear. The question here is, when somebody got multiple blocked on their heart, their arteries, coronary arteries, should you do a bypass or a PCI if your outcome is long-term mortality? That means people living longer, okay? So what they did, because these are two processes, you need to look at the randomized control trial, very high quality trial. So you have to collect all the randomized control trials that compare the bypass with the PCI and put them together in a systematic review and put them together in a meta-analysis. That's what I'm doing. Is that clear? I hope. So what they did, this is the process they follow. As I said, this is their objective, compare the effect of CABG, bypass, compared to PCI on the long-term mortality. Okay. Now they search the Medline, the Medline and PubMed, they search all the randomized controlled trials ever published, comparing CABG and PCI with the multi-vessel disease. So anybody who had not single vessel, multi-vessel disease, CABG versus PCI was compared. So the studies that randomly allocated, some people do cabbage, some people do PCI, and follow up their outcome 5 years, 6 years, 10 years, and so on. Those data were published from a randomized control trial. They collected all of them. And okay, so what are the search terms they use? They use various search terms, something like bypass, CABG, PCI, stent, multi-vessel, three vessel. You have to use British, American, all kind of spelling, but that comes now. It's all been well developed. When you're doing search, you have to learn how to search, but that's a different, I don't want to go into detail, but I just want to warn you, you need to learn about searching. Some people who've done that, they know. That's not enough for you to just look at PubMed only. You should also look at other sources like Scopus. Why am I not, sorry. Scopus, Cochrane. Cochrane has registry of all the trial, Embase, and many other databases. You need to make sure you don't miss any study. If you miss out 1 or 2 studies, then obviously it's biased. Suppose there's one big study which is showing that PCI is better than CABG, but you missed it out, your finding is not unbiased. So you need to make sure you fully include. There is a message, let me just read.
Yes. Lukman, I was going to interfere. There's a request for you to slow down a bit.
I will do that. I'll do that. I can. Sometime I'm taken away unless somebody remind me. Okay, so can I go back to this part slowly? So I'll do that. So our idea is to compare to see, to answer the question. Here is somebody with a heart block, myocardial infarction with the multiple vessels, not one, admitted to the hospital. Now cardiologist has to decide, am I going to do an open heart CABG or am I going to press 10? And what is your outcome? Long-term mortality. Obviously, you wanted the person to live longer. So in order to answer this question, you need to collect all the randomized controlled trials done in. Why randomized controlled trial? They are the highest quality studies that can answer, that can compare two intervention. Here the CABG is intervention, PCI is intervention. When you're interested in intervention, so you should be collecting all the randomized clinical trials. So in order to collect all the clinical trials, you need to do a systematic search. You can start with Medline, PubMed, or with whatever it is you are doing it, and all the randomized control trial. Now there is, of course, there's a filter, and then studies that compare the CABG versus PCI for multivessel coronary disease. You can collect all the randomized trials that randomize people to CABG versus PCI, okay, open heart versus 10. And the kind of search term you'll be using, as some of the examples are here, you would be adding more, you'll be learning more before you do it. You know, you'd level up. Sometimes some of our search terms are like 1 or 2 pages long. And I know Azar did a couple of meta-analysis, and you would know how the search terms, but they're very clear guidelines there from a Cochrane group. There's a lot of handbooks, no problem. Once you decided the topic, it's very easy to develop the search term. Now, what I'm saying here is, it's not enough just you are searching for studies in Medline only. You need to go into Scopus, Cochrane website, which register a lot of the trial, Embase, another big database, Sinahal, another database. So you need to make sure. Sometime, suppose there are some journals in Turkey, they might have run a small randomized control trial, but they didn't publish it in an English-speaking journal or a PubMed journal. Not all the journals in Turkey are PubMed. Most of them are not, to be honest. So you need to go into Dergi or some other databases to pull out those papers too. So the searching, comprehensively making sure you do not miss out any study that compare the CABG with the PCI among the multivessel disease people is quite important. I was trying to say, otherwise it'll be a biased systematic review and a meta-analysis. So I hope this is clear. Is the bar is blocking, or I don't know, I hope. So there were 102 studies came out. They came out with the 102 studies from all their search, and then they had to exclude number of them, because some of them are not randomized control trials, some are already reviewed, non-randomized, did not have mortality outcome. 36 of them, they got the studies, they're comparing CABG and PCI, but they did not have the mortality outcome or any clinical outcome. Maybe talking about pathophysiology or things like that. So they, at the end, found, right now it may be more, I'm talking about at that time, 6 randomized control trials. They found out 6 randomized control trials that compared the PCI versus CABG, and they also had the relevant outcome like mortality and so on. I hope that's clear. This is a flow chart just to show their search process. So they got this 112 search finding, and then they had to exclude number of them because they are not, like for example, 8 were not multi-vessel. So we are not talking about single vessel here. You should have a multi-vessel, more than 1 vessels were involved, or more than 3. I don't know what the definition were for there. So to reiterate, of the 102 results, 6 clinical trials enrolled 6,055 patients. So remember now you have the benefit of using all the patients from this trial. Each of those trials may have 100 patients, 200, 300 patients. Now you are talking about all the patients you are analyzing together. 6 clinical trials enrolling 6,055 patients. 3,000 of them had open heart surgery. 3,000 of them had 3,032 had a PCI. And then you can include all of this patient data in meta. Do not include individual data. You don't have their individual record, but you have their summary record, and you summarize the summaries. So we show you. And they were all having a follow-up. Why is it important? Because we're looking at the long-term follow-up. We're not looking at the hospital outcome. We're looking at after they go home from hospital, how long they lived. So some studies had 1 or 2 years, some had 6 years. So an average about 4 years of follow-up. We would love to have about 10 years, 15 years follow-up, but this is what they had. So we can only summarize the evidence that is there, not evidence that is not there. And then you do a next step. Once you do the search, you have a clear question, you have your search done properly, comprehensively, multiple databases, then you extract the data. Of course, you then exclude studies that are not relevant and only take the ones which are fulfilling your inclusion exclusion criteria, which you should have developed before you're doing it. Then you extract data. Extraction should not be one person, 2 people independently doing it and checking the numbers are correct. If you can do a wrong, 3 as a 33, your answers are all wrong. So 2 people will blindly, or 3 people will be independently, they're extracting data from these research papers, research publication. Then you come together and say, are the numbers correct? It's very, very important to be verified by multiple people. What do you extract from these papers, from these research papers? You extract everything, the numbers, and when did they do it? What are the patient characteristics? What are their age? How long they live? How many died? How long they were followed? Everything that even that you prepare before, you prepare a data sheet in Excel or whatever it is. And these are the variables we're going to collect. And then paper by paper, you extract data. It's quite involved, but it's fun and interesting. So this is the basic data they collected. As you can see, 1, 2, 3, 4, 5. As you know, the 6 studies. As you know, the randomized control studies, they give name. Like a baby is born, you give them a name. The randomized control studies, they give a name. Arts, mass, source, cardia. I mean, they just abbreviated it. And the syntax trial, very well known for cardiologists. Freedom trial is also very well known. People probably know. These are names of the trial, but these are 6 randomized control trials published in various places. Now the trial one, as you can see, 46 out of 584 people died. So 584 people who were given the bypass, 46 died. 590 people randomly allocated to the stenting, 48 died, and look like CABG is a little bit, but we don't know. And then here mass also showed similar trend. SOS is showing 34 out of 500, 53 but 488. So this seems to be no different in cardia, looks like. And then these numbers are reported from Freedom is showing a little bit stronger trend towards CABG. Anyway, these are individual studies. What you do is in a meta-analysis, you would be putting them together to get the final answer. Okay, so this is quite important. I don't know whether you can see here. The mortality, this is what we are after. Our question is long-term mortality according to treatment arm. So I wanted to focus on this one. This is called forest plot here. It's very, very important to understand. This is the main kind of way of reporting meta-analysis. Now, first thing is these are the studies. As you can see, arts, mass, source, cardia, syntax, freedom, 6 of the randomized control studies. The last row is a meta-analysis, which is your meta-analytical finding. Now, each of these studies I showed you here very quickly. Let me go. These are the numbers. How many died? How many were given the open heart? How many died? How many were given the stenting? Now, based on that, you can get a measure called relative risk. I don't want to go into odds ratios and relative risk. Relative risk is basically, our students would know in the later years. Relative risk is basically the risk of death in one group compared to the other group. So arts, it is showing 97. That means about 3% less death in CABG compared to PCI. So that's what it means. If it is 1, that means there is no difference. Is both of them equal death, percentage of people who are dying in both arms are exactly equal, it is 1. But if there's less people dying in CABG, it will be less. So if it is 0.5, 50% less people dying in CABG compared to PCI, which is very good. Or if it is 2, they're twice as likely to die in CABG compared to PCI. So relative risk is something that clinicians need to know, odds ratio, relative risk, evidence-based practitioners need to know. This is the confidence interval. Now, confidence interval, if it crosses 1, that means there is no significant difference. But let's not focus too much on that. I just want you to realize that each of those studies, almost all of them are less than 1, may not be significant, but here it is 1, 1.02. These are all less, okay? But as you can see, this is not significant because the confidence interval include 1, mean although it's about 3% less, but it is 1 is included, means it's not statistically significant. That means there's no difference. In this study, there's a no different. In this study, there's a no different. This study shows yes, CABG is good. This study said no different. This study said yes, CABG is good. This study said CABG is good. Now, when you put them all together, much more powerful, you got 3,023 patients, not 500, 200, 500. 221 deaths and 330 deaths in the PCI, and then your relative risk estimate here, and the confidence interval is very small because of the power. That is what we call pooled estimate, meta-analytical estimate. That is the most important number that you want to work on. How do you interpret this? Simple. 73, that means 0.73 from 1, you kind of come from 1 to 0.73, so it's like 75 is 25%. So it's about 27% reduction, 27% reduction in long-term mortality in people who got CABG compared to people who got PCI. That looks pretty impressive, and it is statistically significant because the 1 is not included in the confidence interval. So some of my first year, second year students know 0 is not included because I didn't teach them a ratio measure, that is the mean difference. But when you come to ratio measure like relative risk odds ratio, we look at 1 is not included in the confidence interval. In any case, as you can see, the p-value is less than 0.001. Individual studies, they're not all significant, some of them are, but when you pool them, it's very highly significantly significant reduction in mortality when people were given the bypass compared to PCI. Of course, don't use this evidence now because this is a bit old study now. There's a lot more new studies come up and much stronger evidence have come up, and you have to look at the American Cardiology Association, keep updating on this issue. This is one of the bread and butter of cardiologists. Okay, so what did they conclude in their paper? But what's interesting, can you imagine how quickly they could publish this paper in a very high impact journal just by looking at the searching the literature, pulling it out, putting them together. Analysis is very easy. Writing it up, there you go, Lancet paper. So significant reduction in total mortality with the CABG, and relative risk is 0.73. That means it's beneficial relative risk reduction in mortality in the CABG. As you can see, the way the favors CABG versus those, so the less than 1 is favoring bypass, more than 1 is favoring the PCI, and the confidence interval doesn't include 1, and the p-value is 0.01. Now you might ask, all right, I mean, mortality wise is okay. What about stroke? What about other things? What about restenosis? What about they need reinfarction? So the paper did not only collect the mortality, they went on to look at other outcome too, to convince the readers even for other outcome, the business is better with the CABG. So this is just to show you, I'm not going to spend too much time. This is how you collect data. Each of those studies, how many patients, how many CABG, how many years of follow-up, what are the outcome they measured, and what type of graft used, what type of stent used, off pump, on pump, and what type of stent, and bare metal or drug diluted stent. All that data you collect so you can do a systematic review to explain if any of these are important. You should also collect data on their age, their gender, whether they have diabetics, hypertension, comorbidities, and all these are very important. Smokers, previous history, ejection fraction, all these allows you to understand your finding in the light of the rest of the data. So when you extract data, you just extract all of this. Now, their primary outcome was the mortality like I showed you, but they also had other outcome. I think time is getting close, so let me just try to, 15 minutes left. Okay, thank you. So, and look at the other outcome very quickly. They look at what is this outcome? Myocardial infarction, that means reinfarction. They're getting another myocardial infarction after this process. As you can see, what does it show? It's almost half. So they got the numbers from each of those studies, how many of those patients got an MI again, and it is clearly favoring CABG. So it's almost, as you can see, the relative risk is even better, 0.58. So almost 43% reduction in getting an MI again if you had a CABG compared to stent. So people who had stent have a higher chance of getting it again, supporting CABG. Don't ask me why I didn't go for CABG, I went for PCI. That's a different story. Okay, so repeat revascularization. I mean, you need, again, revascularization. Again, 70% reduction, much stronger reduction in the CABG. So people who have PCI would need to go back again and a ballooning or giving another stent or putting another stent, restenosis and so on. With the CABG, that's not the case. So 3 of the outcomes are telling us mortality, long-term mortality, repeat MI after the incident, and the revascularization need. All of them are showing CABG is good, except for one, stroke. There was slightly increased stroke, as a 36% increased stroke with CABG, so it favors PCI. So people who had a CABG has a little bit increased chance of having a stroke, but they were a little lucky, it didn't reach 5% significant. Although I don't look at the 5% and 6% important, but in the paper they said, yes, stroke was a little high in CABG, but they're not statistically significant, only 0.06. I don't consider, in my view, stroke was high. I mean, take it as it is high, 36%, but it's not as very high because the numbers are only 93 out of this compared to 67, which is considerable, but not as a huge, not as a huge clinical significant, but statistically not significant, clinically important in my view. And they also put MACE. I mean, the cardiologists probably know MACE is, major adverse cardiovascular events, all of them, bleeding and all that put together as a side effect. And they found 40% reduction with the CABG, even the MACE. So the adverse events with this process is less with the CABG compared to PCI. So obviously, they concluded mortality is significantly low, reduction in MI, repeat revascularization with the CABG is low. There was a trend toward excess stroke. They didn't say this significant. They were lucky that the one is included here. This was not significantly statistically significant. This is what they wrote. I wouldn't be, if I'm a reviewer, I would make them to write differently. There's clinically important finding, but they were lucky because only few events, so fine. So this is their conclusion, as you can see. Let me read it very slowly. In patients with multivessel disease, CABG leads to unequivocal reduction compared to PCI in long-term mortality and myocardial infarction and reduction in repeat vascularization, regardless. Actually, they looked at subgroup analysis, which I'm not showing you. If you're interested, you can go back to the paper, Lancet or a JAMA paper, regardless of whether patients were diabetic or not. So they did a subgroup analysis where they said, okay, let's look at those people diabetic versus non-diabetic. Some studies were done exclusively on diabetic. So let's take this paper and reanalyze. They said whether it's diabetic or not diabetic, CABG is better than PCI. Of course, they said these findings have significant implication for patient care. Indeed, after this paper, there were a lot of shift towards more CABG, no doubt about that. I remember when I was presenting this, when it first came, I said, I don't know why I said that, that's a long time before, long time before, about 15 years ago, I think. I said, here I am presenting it to you, and I know CABG is better in case, God forbid, in case if I get a MI and come to you guys. That was a chest hospital in Kuwait that I was presenting. I think I would prefer a PCI. That's my patient preference. I want to go home within 2 days and to get back to my work. CABG will make me sit on a 1 month and so on. I mean, yeah, so that's where the evidence-based medicine comes in. You have the best evidence, patient preference, and the expertise. So here you go. My patient preference was different. Yeah. Anyway, I mean, I also feel there's a lot of other issues, but this is just for you to show. But again, don't take this as an evidence. I don't think cardiologists will take it from me. There's a lot of updated. I'm using an old paper just to demonstrate because it's very simple for everybody to understand these issues. All right. That's an example. And I got a few minutes as far as saying, and so utility of almost any health policy related intervention. Whatever the health policy related intervention that you're interested in is tested repeatedly. It's not only one study, one done in England and US and Europe and Turkey and whatever. So rather than looking at each of those studies separately, you bring them together and look at the overall big picture, and then you analyze them, and that's what we are doing in a systematic review and a meta-analysis. So we need to look at the body of evidence to treat the patients, to give the best patient care for that. So very quickly, I hope I have a few minutes. Why do we do meta-analysis? It helps you quantify the better treatment effects, increase power, as you see some of them are not significant on its own, but when you put them together, the difference between CABG and PCR became very significant because increased power, which is increased sample size, increased precision, and you can see the differences between the studies. You can settle the controversies, and you can generate more new hypotheses and so on. Okay, so when can we do it? Of course, if you have only one study published in the world, you cannot more than one study. I can tell you, there's nothing in the world has only one study. Almost everything has been studied repeatedly. So don't worry about it. So studies are sufficiently similar to produce meaningful results. See, one is measuring one thing, the other one is measuring entirely different thing. How do you put them together is different. It's always a problem. And the outcome that you're interested in measured in a more or less similar way, and the data are available. Sometime in rare cases, you write to the author and say, can you share me the data in this way because I need the relative risk or whatever it is. Sometimes they respond, sometimes they don't. But most of the time, we have to rely on the publication. How to do a meta-analysis? Identify the comparison or a research question, clinical question you're interested. Identify the outcome that you are interested. Collect the relevant studies. Combine the results, obtain the summary effects, do meta-analysis, and explore the differences between them. So what type of effect size you can use? Relative risk, odd ratios, risk ratios, mean difference, response ratios, correlation, slope of a regression. You can use anything, prevalence, incidence, you name it, we can put them together as long as there's a number. How do you do it? Good news is software. Here are so many: Startra, CMA, Rivman, R, MetraXL. MetraXL, we developed it, is a freely available, but it's a little bit complicated. SAS. SPSS, that's very limited. I won't recommend it. Medical can do it, mixed metawin, and list goes on. R is free to do. I tend to be more startup person now. I use CMA and RATA and Rivman. Of course, I'm a member of Cochrane, so I had to use Rivman. MetaXL is our software, so I used to use some time. Okay, so very quickly, for example, I can show. I have a few minutes. I'll try to just show how the software works. Only 2 minutes.
Yes, of course.
Okay, so suppose there's a question like this. My daughter had a preeclampsia, so I was looking at the evidence one day, and I said diuretics. Everybody knows the type of medication is a blood pressure medication. They give it. I mean, I don't know the students are aware of this medication type, but diuretics is a type of medication. And if you give diuretics to people who are high risk for preeclampsia is, your cord become toxic and create trouble, and you need to be taken the baby out to save the woman. So if the diuretics reduces the preeclampsia in a pregnant woman who are high risk, is your question. So what you do is you look at all the randomized control trial that you're looking at giving diuretics versus a control, which is placebo, non-diuretic or nothing given, and looking at the women who are high risk in preeclampsia, how many of them develop preeclampsia, and then we can look at it. It's like, for example, say Wesley, one study, how many 14 develop preeclampsia out of 131 who were given diuretics. In a control group, 14 developed preeclampsia out of 136 who were not given any medication. It's a placebo group, control group. So there are two groups. You see how many got the outcome out of how many were given. So you need these 4 numbers, 2 by 2 table. And in the software, this is a comprehensive meta-analysis. You just put the study name Wesley, and the 14 treated got preeclampsia, 131 was treated, 14 non-treated got preeclampsia, 136. You only enter these 4 numbers. All these yellow columns in CMA, they calculate the odd ratio, confidence interval, everything. So you just enter those white columns and the yellow column software. Very simple, extremely simple. And then when you enter one by one, as you can see, there are a number of studies you enter. You enter those numbers extracted from each of those studies, and then it calculates the odd ratios, it calculates everything. It calculates the pool data, and it produces you the forest plot. This is what the forest plot means. Forest plot gives you the overall estimates and the confidence interval, and for each of those studies, it gives you what is the point estimate, in this case, odd ratio, and the confidence interval. Like, it looks like a forest. That was called forest plot. Some people say the guy who developed was a David Forrest first from Oxford. Whatever the reason, it's called forest plot right now. Looks like a forest to me. Okay, so these are the studies that we included. This is the overall meta-analytic estimate. As you can see, the diamond is the overall estimate. These are each of those studies. The bigger square shows the bigger studies. Smaller square shows the study was small. And as you can see, my first year and second year students will immediately tell me that longer the confidence interval, their smaller sample size, the smaller confidence interval, like the big square, is bigger sample size, and so on. So you pool it. This is your pooled estimate, significantly reduces, but again, this is updated. Don't take evidence from my presentation. So that's pretty much I want to show you. I don't want to go into the deeper areas later on, maybe. Just to show you some of the things I could do very quickly. This is one of my master's students looking at whether the antibiotic prophylaxis is useful before you do a surgical abortion. There you are, we publish in BJOG, and very quickly, Nazmul was one of my master's students. It's a good journal, BJOG, and it didn't take long for us. We just pull out all the randomized trials, put them together, and we said, yes, antibiotic is helpful. And we look at this, the COVID. I remember when Trump was talking about chloroquine, I was listening to it, I was telling Suhail, why don't we look into that, whether it's true? Honestly, we were very inspired by Trump. There you go, there are people that inspired by people like Trump. So this is one of us. So we said, oh, chloroquine, let's look at it. So we looked at chloroquine is good for COVID infection or not, and we did the meta-reviews. There were many meta-analyses, we put them together, and we found absolutely no use of giving chloroquine for COVID infection. And this is against steroid. My group of people who were working with critical care, they said, should we give corticosteroid for the people who are in ICU COVID? We did that, published it very quick. We looked at metformin for gestational diabetes, a lot in Qatar and Kuwait. So friends of us said, is there anything we can do? So why don't we look at the metformin? Good old drug, everybody know. So we looked at metformin is helpful for GDM or not. There you go, published very quickly, obesity review. And physical activity, then we said, what about physical activity? Does it reduces? There you go. And we looked at, this is my Cochrane, I'm a member of the Cochrane group and one group, and we're looking at pressure ulcer. By changing the repositioning, does the pressure ulcer prevention works in adults? And we did that. We did many on that, about 5, 6 on pressure ulcer with the Cochrane. This is something we did recently. We said, what is the surgical site infection among general surgical patients? We use 488,594 patients. I don't know, 4 million or whatever, I can't remember, I can't count. Statisticians can't count, as you know. And then we just looked at what are the surgical site infections in general surgical patients worldwide. We collected all the studies around the world and did that. Again, we did this is one of my students, I think. Yeah, he's a PhD student in Griffith. Zhao, yeah, global prevalence of pressure injury in hospitalized patient. We also did in ICU patient, another critical care. We did about 30 meta-analysis right now, and we're doing a lot more. And this is a master student, again, looking at the necros, a pediatrician interested in neck, necrotizing enterocolitis. What is a global incident? Pull out all the papers and publish. And this is my very first meta-analysis I did in 2006. It went to American Journal of Critical Care. You know, the socks you wear for the pneumonic socks when you fly. So we're looking at mechanical, that socks help the mechanical thrombophylaxis in a critically ill patients. And there were only a few studies, but we did it. And since then, I've been interested in it. Yes, that's basically I wanted to show. This is one of those papers that we are very interested in, because we were interested in the quality of the studies, Because if the quality of the studies are bad, your meta-analysis is also going to be bad. So Suhail and I published this in epidemiology on a new model. This has been having a lot of hit on us, on our paper. Anyway, so I'm going to go straight into conclusion due to the time. Meta-analysis of large number of studies allow testing of a hypothesis regarding healthcare and health policy intervention. Heterogeneity and biases can be a major threat. I mean, basically I'm saying if the studies are weak or poor, your conclusion are going to be garbage in, garbage out. If the studies are good, your conclusion are going to be good. I think I should stop there, Zaina Hoja, and if you allow me, and now you can take question.
Yeah, of course. Why not? Yes. Now, so we're finished. Will you add anything else, Lukman?
I had few more slides, but
Okay.
I hope people get I just want people to know that meta-analysis is quite important for clinical care, and also to understand it's not a big deal among academics who are interested in publishing things. If they're prepared to sit down and look at the published literature and come up with a very good question, they will be able to do a meta-analysis fairly quickly. I don't know, Ozer may not like me quoting him. Ozer did a meta-analysis in, I don't know how long it took Ozer, 2-3 weeks, is he there? Ozer did it maybe 3-4 weeks meta-analysis. Yeah, and so people, I mean, sometimes we did it in 4 or 5 days also when we fully engage in it. Yeah. But it's a matter of coming out with a real good question. And they also remember a lot of people are trying to do meta-analysis. There's a huge number of meta-analysis coming from China. Yeah, there's a lot of push in China for research outcome and competing with US. And so because meta-analyses are easy to publish, a lot of the top journals like meta-analysis, like randomized control trial, when you come up with a very good topic, and then you do that in a very proper way, and which is very easy. Analysis softwares are just click of a button, you get the answers. But you need to go through rigorously, and then publication potential is very high, and you feel happy that it is getting used in clinical care. Yeah. Anything else? Arta, wanted to add something or any other question?
Yeah, we have some questions, and from the audience, from students. Arta has sent some of them.
Can you read that through for me, because I can't necessarily.
Yes. Yeah. One is there a bias in meta-analysis, and how do you avoid it?
Absolutely, absolutely. So it's called garbage in, garbage out. So what happens is the number of biases. One is a publication bias. I mean, you did a study and you did not find a significant difference. You did not publish it. There's no way that we can figure it out. Somebody has put it, it's called a file drawer problem. You put it in the drawer and you locked it up and I don't want to publish it. Or you did it in non-English language and you didn't want to write in English language, you didn't get by. So those studies have valuable data related to the same question you are investigating, but that is not there. So you may have found PCI is better than CABG, but you didn't publish it. So I can't include it to make it look better. So this is a problem. What we do is we just look for conference presentation. We look at the non-English language papers, and to write to the authors, if they're a group, we know somebody is doing a trial, we will write to them, have we got any preliminary finding, and so on. Now, because of this issue, what people are saying, before you do a clinical trial, it doesn't matter which part of the world, you register that. You register it in Cochrane, you register it in various places. So we look at the registry to see anybody is doing any of these trials, and we write to them to see, have you got any data or anything started, or have you published that we are missing, even if it is not in the language that we have interest in. So there's a lot of biases, but let's ask this question. Do you rely on one randomized controlled trial from, say, US, Europe, or wherever, or do you rather include 20 randomized trial, maybe 1 or 2 missing? Obviously, the more, the better. You know what I mean? So bias in meta-analysis, in my view, is much less than bias in a single study. Almost all the single studies are biased in one way or the other. So when you put them together systematically, I think the bias is less. There are other biases too, like But almost all these biases are being mitigated or you need to try to be. If you want to publish in a leading journal, you need to convince the reviewer we looked at all those biases. Yeah. And also we do risk of bias for each of those papers, and then you can reanalyze it using good quality papers versus bad quality papers. Are the good quality papers giving you the same answer as the studies? Yeah. Is that answers the question a little bit?
Yes, and choosing and writing in various formats, the keywords is important in screening the pre-published literature.
Absolutely, absolutely.
It's very
That's why we say don't stick to Medline only. Do MBase. So Cochrane guidelines are there. The Cochrane handbook, I recommend anybody planning to use Cochrane handbook. They would say minimum 3 databases one should search on. Minimum. I would recommend looking at multiple databases. Okay, so pay attention to for example, if you're looking at the salt and blood pressure, there's a lot of Japanese studies they were looking at. They got a lot of salt. So you need to understand that I need to look at the Japanese language literature as well a little bit using translated. So the Ruth Gilbert, with whom I was working in London, I mentioned the one who was on the court death. She has a translation team. You know, they got translators of multiple languages. We don't have that kind of center here. So most of the meta-analyses are done using English language papers, even mine. So bias is very much possible of that language bias. But if you're sure that a lot of, so if you're talking about the herbal medicine or a Chinese tea then you need to include Chinese, Japanese, Korean papers, for example. You know what I mean? Yeah.
Yes.
So if you're something you're interested in Turkish, obviously you have to go into Turkish language papers because a lot of the Turkish journals are not in PubMed, unfortunately. Malasaf. Yes.
Okay. And there's another question. Does a meta-analysis have a hypothesis? Well, in fact, you have mentioned that.
Yeah, meta-analysis is a study design like a randomized control trial, cohort study, case control studies. You have a hypothesis. To answer a hypothesis, you will use a randomized control trial. Like that, you will use a meta-analysis to answer your hypothesis. If your hypothesis is related to a population and a particular outcome, whether this intervention is better than the other, or your hypothesis, does cigarette smoking increases the lung cancer, or your hypothesis related to is the genetic risk is high for particular kind of markers, all of them. To be honest with you, currently I'm doing a meta-analysis with engineers, actually, environmental engineers based in Texas. They were interested in using 2 kinds of fiber in desalination of the water. You can do it in every field. It's not related to medicine only. Sociology, any field where data is collected, studies are repeatedly done, you can do meta-analysis. So it's not only medicine and healthcare, but we are ahead compared to the rest of the world. Dentists are very good in meta-analysis. They do a lot of them. Yeah.
Okay. And one more. Can meta-analysis be done without a systematic review?
You can actually. To be honest, you can. But I wouldn't recommend it, at least to a smaller systematic review. Well, see, what are the systematic review? Systematic review, you have to systematically search the literature. You need to do that for meta-analysis. Inclusion, exclusion criteria, you need to do that for meta-analysis. And what you're talking about, maybe I know some people who write very little, one section on systematic or narrative kind of review about the papers. So all their paper is about meta-analysis. Yes, it's possible, but I wouldn't recommend. I mean, see, some papers are purely systematic review. They don't have a meta-analysis. They say, these are the studies related to it. We analyze it and making some tables, and some studies are of this nature, some are here, this stuff from this countries, this many, and so on. Patient populations are this average age and so on. That's what they call systematic review. What they're saying is, I don't want to put all these numbers of the outcome, or it's not there for me to pull them together in a meta-analytical forest plot way. But when you have meta-analysis, you can obviously write about systematic review, but some people write 3, 4, 5 paragraphs on systematic review. You can reduce it to 1 paragraph and fine. I have done that. But when you do a meta-analysis, you need to do a systematic review, but they're talking about reporting. Some people ask me all the time, I don't want to write a lot about each of those papers, where they come from, what their patient populations are, what are their average age, what percent. I said, fine, that's fine, but you need to do the process similar. Research is the same, inclusion, exclusion criteria is the same, and so on. Yeah.
Okay. In one of your slides, it was comparing the increase in numbers of systematic review and meta-analysis, and it showed that until 2001, it showed that systematic review numbers were both were increasing, but systematic reviews were more in number than meta-analysis. Is there a specific reason for that? Because it seems that meta-analysis is much more useful than a systematic review, and also it forwards the issue to somewhere with very concrete evidence-based data. So looking at that and thinking about all these, one thinks that people should go, should rush to meta-analysis, to making meta-analysis, and to using meta-analysis outcomes. So what's the reason for less increase in meta-analysis numbers?
Yes, always there's more systematic review than meta-analysis, because now it is not the case. I think it can, because the reason being systematic reviews done, like for example, like you real example, my cousin just finished a PhD in pharmacy in Sydney, and she just sent me her publication. I said, Sakina, why didn't you do a meta-analysis? No, I didn't bother. We just did the systematic review and published it. They do the systematic review without doing. I didn't want to. Why didn't you? I would have done 5 minutes for you, the analysis. Oh, we did it anyway. I got my PhD later. That kind of thing. People get scared of doing meta-analysis. They think it's too complicated. Get a software, enter the data. So systematic review doesn't require a statistical process. It's just combining and
Is it only that, or is it also that it brings you to a specific outcome which can influence also the guidelines and therapies and diagnostics, and so it may change something, and you should have the the courage.
Yes, I agree.
Some results.
I agree, but one of the problem is, suppose you have 5 studies, is only 5 studies or 10 studies, whatever, but each one of them are reporting the outcome differently. You see, that's the problem. So you're looking at the long-term outcomes, say only one study reported longer-term outcome. All the other studies are reporting hospital outcome, in-hospital mortality. Then I can't look at it. This is the thing. You're interested in quality of life, say CABG, PCI. Only one study reported using one method, SF32. Another, I'm having right now a problem. Another study reporting using SF12 or some other kind of quality of measures, or just some people asking how good it is. So different people, amazing world. Different people study the same thing differently. Sometimes you can put them together, like SF12 and SF32, you can merge them together using transformation. I do a lot of such thing and bringing some of these outcomes closer to each other. If it's a relative risk, somebody report odds ratio, I can convert them and make them relative risk, no problem. But the problem is sometimes they don't report anything. And then you write to them, can you send me the numbers? Sometimes they do, sometimes they don't. More and more people are doing now because they know their paper gets cited in our paper. So they are responding. For us, we have got very good response. So it is an author's choice, but we always recommend, when you can do a meta-analysis, please do. But when you can't do it, please say why you couldn't do it, because there is insufficient data, or different people are measuring different outcome, and we couldn't see at least 2 or 3 people reporting the same. Does that make sense? Yeah, that's why more systematic review then. By the way, that curve is until 2011, but if you look at now, it's much more. I want to update that, hopefully, because it's gone up exponential now, yeah.
And also, Arta has a last question, let's say. I think we can make it last. Probably, yes.
Yes,
She asked that how health policies benefit from meta-analysis studies.
Of course, health policies. Health policies, you decide what kind of intervention health policies, you decide about what kind of policy decisions you make. So as soon as you have a choice or options to go for this or go screen or not to screen, for example, should we screen for breast cancer or not? Should we screen for certain cancers or not? As soon as you have to make a decision, you look at all the papers that published on screening benefit and not benefiting and harming or early diagnosis, all that, and then you put them all together and you can do systematic reviews and meta-analysis, and that will be that should be allowing us to take the right decision for health policy intervention, health policy decision. Does that make sense, Arta? I mean, the question, I mean, I remember we were working with Ruth Gilbert on breast cancer screening in England. Not always, not all the screening is helpful. Sometimes screening could be harmful.
Yeah, you're right.
Yeah. So
Thanks a lot.
Yeah, does that make sense? I hope you will do some meta-analysis with the health policy intervention group.
Yes, exactly.
Whatever the policy decision that are pressing Turkish need, that's where you should start. I think people should start on the clinical impetus, like, you know, clinically what pushes them, what is the clinical question that require a very good answer, then that's a good beginning in my way.
Okay, so are there any other questions or contributions to the issue? If not, I think, Lukman, you should be tired.
Not really. I can talk about meta-analysis all my life. I don't get tired. I'm sorry, but I tried to speak slow, but I think I just get back to it.
And it makes one, you know, more tired. I know, because your normal rhythm is very fast. So
I am a little fast person. That's the only thing.
Makes you tired.
That's the only thing makes me a little bit edge. Otherwise, nothing else.
Okay. There's one more question. Does Professor suggest using R software for meta-analysis?
Okay. People use R because R is free. Okay. People use R because R is free. When using R, you need to be careful. R is based on anybody around the world putting that, you know, macro. So it's not old. Like hundreds of softwares to do regression or meta-analysis, meta-regression. So you need to be, first of all, make sure whatever the package you're taking is reliable. And it is free and everybody use R because it's free. I know people who developed it, but I don't use R because I have Starter, alhamdulillah, so I use Starter. Is much better output and so on. But if you are not having access to paid software, I don't see any reason why you don't use R, but be careful which of the package. So double check the software using is correct, not like, because R has so many macros, which macro you're using is validated and somebody has said good about it or they vouch for it, and then it's fine. Nothing wrong with that. I mean, I don't like some of the R output, that's fine. But if you are a student who is asking, I don't know, the students can get starter access very cheap, you know, I don't know, $50 or something for starter license for students, not for us. Then you can use Starter. You love it once you start using Starter. Yeah.
Okay. So Lukman, thank you very much. It was a very warm hour and it was very interesting, and I'm sure all of us, all audience benefited from your slides and your, you know, introducing the issue. Meta-analysis is not a very well-known issue actually, but it's getting more and more popular as it is in the whole world, but more in Turkey maybe. So, but it is a real support for medicine, I'm sure, in all aspects. So,
thank you very much. I think we're going to see the effect.
Stay here.
We're going to see some, if there are meta-analysis coming through medical school within the next 1 year, how many meta-analysis come, maybe the outcome we're going to measure the effect of this webinar.
Well, I was going to say that we may see some more meta-analysis from our teams.
Yes.
So,
Not to count my ones.
okay, so thanks a lot, really.
Thank
We're
you.
waiting for more webinars from you
İnşallah,
from
inşallah.
time to time, of
Yeah.
course.
Çok teşekkür ederim.
Thanks a lot for your time.
Okay, bye bye.
Çok teşekkürler katılım için. Tekrar sorularımız olursa WhatsApp'tan da devam edebiliriz tabii. Teşekkürler. Hoşça kalın. Bye bye. Lukman.
Hoşça kalın.